Nephrotic syndrome is the clinical manifestation of a group of glomerular diseases in which the proteinuria is greater than 3.5 grams per day. So basically this concept is very simple. I will explain it to you right now. Just a second. Okay. So we have our Bowman's capsule, okay, and here we have our renal tubules. Okay, this is the loop of Henle, distal convoluted tubule, and the collecting duct. Here we have our renal capillaries, right? After the afferent arteriole, and over here is the efferent arteriole, afferent arteriole, and the renal capillaries. So basically, before something filtrates normally through the glomerulus, it has to pass a barrier. This barrier includes, first of all, the glomerular basement membrane. Okay, it includes the glomerular basement membrane, and along with the basement membrane, it also includes the podocytes, okay. Podocytes are epithelial cells which have a foot-like process in the end, like this. You see, a foot-like process. There are epithelial cells with foot-like processes called podocytes, and of course the endothelial cells, in which everything is filtrated. So basically what happens is everything that filtrates has to pass a size barrier. You see, it has to slit between the glomerular basement membrane and the podocytes. The thing is, we have low molecular weight protein such as albumin, which normally shouldn't be filtrated in our urine, because we are not supposed to have protein in our urine, or maybe in a very small amount. So what prevents this albumin from filtrating, because its size is just enough to slit through the glomerular basement membrane and the podocytes? Okay, the albumin is negatively charged. Okay, proteins are negatively charged. The idea behind this is that the glomerular basement membrane and the podocytes are also negatively charged. So whenever the albumin will try to pass, okay, whenever the albumin will try to pass, it will be repelled back. It cannot pass because this is negative and this is negative. The problem begins when there is some kind of glomerular injury which disturbs this charge and converts it from negative to positive. Now, of course, whenever the albumin will try to pass, it will succeed. This condition, if this injury is very minor and we don't have any structural defect to the glomerulus, only an injury that affects the charge, this is called minimal change glomerulopathy. And you will see in this condition, you will see selective, right? Selective protein urea, P urea, because only albumin will be small enough to filtrate, and because there is no structural defect, only change in the charge. So next problem that can occur is that if we have a more severe injury to the glomerulus, severe injury to the glomerulus will now start to disturb the structure of the glomerulus. So basically what could happen is that food process of the podocytes will be cut off, okay, and the glomerular basement membrane will start to be leaky. Now, not only albumin can pass more easily because it has the advantages of the charge barrier, of the change of charge, and also leaky glomerular basement membrane and the podocytes, they like cover less space because the food processes are cut off. So now even globulin, which is a large protein molecule, can slit through. So this results now in non-selective, okay, non-selective this is terrible, I'm writing with my mouse, so please forgive me. Non-selective proteinuria. Now back to our presentation. So the main idea behind nephrotic syndrome is that our proteinuria, the injury to the glomerulus is so severe that proteinuria is more than 3.5 grams per day. Now, as a result of the proteinuria, of course we have loss of protein in our blood, so this will result in hypoproteinemia or hypoalbuminemia. Because of the loss of albumin, we have severe loss of albumin, so hypoalbuminemia. Hyperlipidemia. Okay, let me explain to you this concept. Just making new. Okay, why does hyperlipidemia occur? We'll draw another glomerular unit. Yeah, this is just a concept, okay? It's not like this is how the glomerulus looks like, just a concept in order for you to understand. This is the proximal convoluted tubular cells. Let's make it like this. Okay. So basically, why hyperlipidemia occurs? Because we have a leaky glomerular basement membrane and disturbance in the podocytes, more protein is lost. A lot of protein is lost. Actually, when you see in the urine more than 3.5 grams of protein daily, it doesn't mean we lose only 3.5 grams of protein. We lose more. The thing is, let's say 10 grams of protein are filtrated daily and you only see 4, you could only see 4 grams of protein daily in our urine. So if 10 protein filtrates and you only see 4, what happens to the rest of the protein? They get reabsorbed in the proximal convoluted tubular cells. So let's say 10 grams of proteins are filtrated daily. You could only see like 4 or 5 grams in the urine and 6 or 5 grams will be reabsorbed. So our liver, basically what it does, it compensates for the protein loss, and the liver could compensate up to making a daily amount of between 10 to 12 grams of protein per day. Okay, so this is basically the concept of the liver compensation by making proteins. But the bad thing is that the liver compensates, it likes to compensate by making LDL. LDL, as you may know, it means low density lipoprotein. It's basically a transporter of cholesterol. And this is the bad transporter of cholesterol, because HDL is the good transporter of cholesterol, high density lipoprotein. Basically what it does, that if we have free cholesterol in our blood, then HDL transport it to the blood vessels and then back to the liver for a process like gluconeogenesis or so on. And LDL basically deposits the cholesterol in our blood vessels, and this is a bad lipoprotein because it makes us predisposed to a disease such as atherosclerosis, and this is why we have a condition of hyperlipidemia and hypercholesterolemia. Okay, so back to our presentation. Edema. Why does edema occur? Edema. Why does edema occur? I will explain it to you right now. Let's just delete this. Okay, why does edema occur? Let's just do a concept like this. Okay, this is our blood circulation. Let's suppose this is our blood circulation, and this is a tissue. Tissue in our body, right? So basically, let's just assume it's a capillary, okay? Because the exchange between tissues and blood circulation goes through a capillary. I know this drawing is terrible, but let's just imagine that this is a capillary. So basically, because we lose a lot of protein, okay, we can lose like 10-12 grams of protein daily, and we, again, I should mention that once we see more than 3.5 grams of protein daily in urine, it means we have nephrotic syndrome, the manifestation of nephrotic syndrome. So what happens is we have reduction in oncotic osmotic pressure, and as you know, there are two forces that work between capillary exchange and tissue exchange. This is the hydrostatic pressure and oncotic pressure. Hydrostatic pressure pushes the plasma fluid into the tissue, and the oncotic pressure is what pushes it back after the exchange. You know, O2, CO2 and other nutrients, once they exchanged, then the oncotic pressure pushes it. Because hydrostatic pressure is normal, then the tissue will be pushed normally, but oncotic pressure is low. So what will happen is that a lot of the plasma fluid will stay in the tissue, and this will result in edema, and the edema will be unpitted edema, because over here we have a lymphatic duct that drains proteins that have diffused to the tissue, but the lymphatic duct will be normal, so it will drain the plasma proteins, and what will happen is that only plasma fluid will remain. It will result in unpitted edema. Pitted edema is when we have block of the lymphatic duct, but this is not the case, so we have unpitted edema. And this edema could be localized edema or anasarca, generalized edema, depending on the severity of the glomerular injury. Hypercoagulation. Why does hypercoagulation occur? So hypercoagulation occur because along with all this stuff also, along with all this also due to the glomerular injury, antithrombin 3 get filtrated. Antithrombin 3 is an anticoagulant protein, and if we lose an anticoagulant protein, it means we are in a hypercoagulable state. So those patients tend to suffer from hypercoagulation and a tendency of thrombus formation. Hypogammaglobulinemia. Hypogammaglobulinemia basically occurs because we have also loss of gamma globulins because of the structural defect, leaky glomerular basement membrane, and food processes of the podocytes that are cut off allow gamma globulins to slit through, and a group of the gamma globulins are the immunoglobulins, and this condition of hypogammaglobulinemia and the loss of immunoglobulins will cause us to be more susceptible to infections. Nephritic syndrome is a condition where there is a severe inflammation to the glomerulus, and due to this severe inflammation, what will be the result is a capillary compression, okay, the capillary of the kidney compression, and due to this compression we will actually have a reduction of glomerular filtration rate. Okay, so let's say we will do T-lyl cells over here. We have a proliferation over here. Okay, proliferation. Now, why does that proliferation occurs? Because of the inflammation, we will have a presence of inflammatory cells like neutrophils and macrophages, right? And they will basically release growth factors. And they release growth factors, which will cause cells to proliferate. And this proliferation of the cells will compress the capillaries, and due to the compression there will be less blood flow, and due to this the glomerular filtration rate will reduce GFR. Okay, so due to the reduction glomerular filtration rate, as opposed to nephrotic syndrome, our glomerular basement membrane isn't leaky, and our podocytes are somewhat normal or totally normal. So we may, in the worst case scenario, we will only see like a mild proteinuria, and this proteinuria will be less proteinuria, right? In urea will be less than 3.5 grams per day. So this is a kind of a diagnostic value, because in nephrotic syndrome our proteinuria is more than 3.5 grams per day, and in nephritic syndrome the proteinuria is less than 3.5 grams per day. Again, this is because of that in nephritic we have a proliferation of the glomerular cells which compress the capillaries and reduce the glomerular filtration rate, and in nephrotic syndrome we have leaky glomerular basement membrane and damage to the podocytes, and also to the charge of the glomerular basement membrane and the podocytes. So this what allows the protein to leak out. So due to this proliferation, the compression of the blood vessels of the capillaries, it may actually cause a capillary to rupture, and this rupture will cause blood flow, blood to slit into the renal tubule, and this will cause a condition called hematuria. Hematuria means we have blood in our urine. Okay, so blood comes out through our urine. Now this blood that comes out through our urine, actually when the blood slits through, it will be arranged in the tubule in the shape of the tubule. It means like this. It will, you see, our tubule is like a tube, renal tubule is like a tube, so it will be arranged like this. Okay, let's say it's a lot of blood vessels, it will be arranged like this, and it will get the shape of the tubule. So once it will be pushed all the way, okay, it will be pushed all the way to the renal tubule, it will come out like this, just as you see, like a cube, like a cast, So this condition is called RBC cast, and in the urine analysis you will see RBC casts in urine. You actually will see small pieces of blood, okay, shape like this in your urine. So this is basically the main idea. Now, like I said to you, the proteinuria will be limited because of the reduced glomerular filtration rate, less than 3.5 grams per day. Oliguria, again, because of the reduced glomerular filtration. So oliguria means we have less urine production. Periorbital edema. Periorbital edema occurs because we have reduced urine production, so we have more water and salt retention, and this water and salt retention increases our blood volume. Because our blood volume increases, it will increase the hydrostatic pressure, and it will predispose us to edema. And why does periorbital edema occurs? Because it loves, in nephritic syndrome, this type of edema loves to accumulate in a loose connective tissue, because it's easier for it to accumulate more in a loose connective tissue, okay, because it's loose. So our periorbital tissue is a loose connective tissue, so it will result in a periorbital edema. Hypertension. Why does hypertension occur? So basically, because we have a reduction in the filtration rate, we have less sodium chloride filtrated, but besides that, okay, sodium chloride, sodium is positively charged, sodium chloride filtration is less, but because the overall glomerular filtration rate is less, it means that all the things that filtrate and pass through the tubule pass it slowly because it's less filtrated. It's logical that if we have more filtrate, it will pass fastly, and if we have less filtrate, it will pass slowly. So if it passes slowly, it means this, especially the sodium chloride, they have more time to be reabsorbed. Okay, so they are reabsorbed in the proximal convoluted tubule, and a very small amount will reach this area of the distal convoluted tubule. And on the distal convoluted tubule, we have, of course, the juxtaglomerular apparatus. And juxtaglomerular apparatus, along with the macula densa, they are present over here, and they sense this small amount of sodium chloride, and due to this they will increase the release of renin, right? Renin. And this is their way of trying to increase the perfusion to the kidney, because they sense there's hypoperfusion, because they think there is hypoperfusion, but actually there's compression of the capillaries and less filtration. Maybe the perfusion is normal, but anyway they will release renin. So renin will go to our liver. A lot of action goes in the liver, so it will go to our liver, and it will act on the enzyme called angiotensin again. And they will convert it to angiotensin 1. Angiotensin 1. Angiotensin 1 will go to our lungs, and in our lungs the enzyme angiotensin converting enzyme will convert angiotensin 1 to angiotensin 2. Now this will cause a couple of changes. First of all, angiotensin 2 is a powerful vasoconstrictor, so basically it will constrict the arterioles, and the constriction of the arterioles will cause the total peripheral resistance to increase. TPR, total peripheral resistance, will increase because the arterioles will be constricted. So this constriction of the arterioles will actually cause the ventricles, they will cause them to have to produce more force in order to push the blood through. So due to this, our diastolic blood pressure will increase. Total peripheral resistance affects the diastolic blood pressure, so it will increase. And they also will constrict the venules, and the constriction of the venules will cause end-diastolic volume to increase, because more blood will return to the ventricles, so we have a rising end-diastolic volume, and this will increase the cardiac output, and an increased cardiac output means increased systolic volume, so both systolic blood pressure, so both systolic blood pressure and diastolic blood pressure will increase, resulting in hypertension. So this is a unique thing for nephrotic syndrome. We have a condition of hypertension. But besides that, angiotensin II will go to the zona glomerulosa of adrenal cortex. As you know, zona glomerulosa have 3 layers. Okay, there's 3 zones. The innermost zone is zona reticularis. The middle zone is zona fasciculata, and the outermost zone is zona glomerulosa of the adrenal cortex. Okay, not the adrenal medulla. This is all the adrenal cortex, and it's 3 zones. So it will work on the adrenal cortex in this, and on this it will increase the release of, or cause the release of aldosterone. Now, aldosterone is an hormone that, first of all, it will act on the principal cells of the distal convoluted tubule and the collecting duct, and basically what it will do is causing more sodium and water retention. So more sodium, and because sodium goes, it drags with it water. Okay, when sodium is reabsorbed, drags with it water, it will reabsorb back to our general circulation. This will increase the total blood volume, because we have more water in our circulation, more sodium, the drugs with it water, so our blood volume will increase, and this will again increase the diastolic and diastolic volume and the cardiac output, further increasing the systolic blood pressure and doing a worse hypertension. And maybe if you do not know that aldosterone can also affect the heart, and if a lot of aldosterone will be released, if a lot of angiotensin II will be converted and act on the zona glomerulosa of the adrenal cortex, a lot of aldosterone will be released. It also affects the heart, and it causes cardiac remodeling, which basically it's a structural morphological change of the heart, which could be dangerous. So there you go. So hypertension, you already know why does it occur. Azotemia. Azotemia occurs because we have reduction again in glomerular filtration rate. So it means that due to the capillary compression, a lot of things that should have been filtrated, they are not filtrated. So things like urea or creatinine that normally filtrate, that normally should filtrate, they are not filtrated, and there are those nitrogenous waste products accumulate in our blood, and they will result in a condition which basically is called azotemia. And azotemia means a change in the blood chemistry, okay, in the chemistry of the blood. And hematuria, RBC cast, again because the capillary rupture, we have RBC slitting going into urine, and they get the shape of the tubule and they come out looking as an RBC cast. So we will finish this lecture by doing a small comparison between nephrotic and nephritic syndrome. The main thing you have to remember about nephrotic syndrome is that we have hypoproteinemia. This is because we have hyperproteinuria of more than 3.5 grams per day, with the liver trying to compensate but can't. Because the hypoproteinemia, we will have a condition of edema, due to the reduced oncotic pressure, which can be localized or generalized, anasalca, and because the compensation of the liver resulting in production of low density lipoproteins, we have hyperlipidemia or hypercholesterolemia. Except don't forget also that we lose antithrombin 3, which result in hypercoagulation, and we also have a condition of hypogammaglobulinemia, which have us in a state of increased risk for infection. Nephritic syndrome, as opposed to nephrotic syndrome, we have oliguria with a mild proteinuria due to the reduced filtration rate. So we'll have mild proteinuria of less than 3.5 grams per day, so it's diagnostic between nephrotic and nephritic. Hypertension occurs because of the reduced glomerular filtration rate and the sensing of the macula densa of the reduced sodium chloride, because they have more time to get absorbed in the proximal convoluted tubule, and generally less of them filtrate, so it will release renin, which will increase eventually the levels of angiotensin 2, which will cause an increase in aldosterone by affecting the zona glomerulosa of the adrenal cortex. And the condition of hematuria is due to the rupture of the capillaries because of the glomerular cell proliferation. Okay, so as you remember, nephritic syndrome is a state of inflammation of the glomerulus, and it will bring with this state inflammatory cells, which will release growth factors that will affect the glomerular cells, will cause the proliferation and the compression of the glomerular capillaries. This is why oliguria occurs, but also it may lead to a rupture, so hematuria occurs, and of course the red blood cells filtrating will get a shape of a cast, because they will go inside the kidney tubules. In there they will acquire the shape of a cast, and then a strong force will come, push them out, and they will come out as a cast.